So first of all, thank you very much for this nice introduction, and it's always a very nice feeling to be back here. And I know some of you, and again, very good to be seeing you again. All right, so here I will talk about some of the topics that I have worked on, and I was expecting a bit few more students than what I now see in the crowd. So some of these things that I will be describing, there is a high chance that you have seen it in some form earlier in your as part of your maybe even curriculum. But here what I'll try to do is to kind of, given that there is also an interdisciplinary audience, I'll try to go through some of the methods and the more like the philosophy of the methods as to why economists prefer them. My plan is that I will spend first, maybe 1/3 to half of the time building some intuitions around that, and then I will get into the specific some research problems where we have kind of applied that. All right. So one of the things, this is something that I have been very interested in learning about, is fundamentally what is causality. In the sense that I'll be talking about it primarily from the economics background because that's what I kind of understand. And one of the problems is that, or one of the setups that you have in economics is that you start thinking about something in the form of something called ceteris paribus. What it means is that keep everything else unchanged, change only one variable, see how does the system react to it. Nice theory, but does not quite work in practice. In reality, practically everything evolves at the same time. So it becomes a bit problematic in order to kind of segregate out or tune only one particular parameter and then attribute the resulting changes in the system only to that particular tuning parameter. So then what is the other option that we have? Well, so we employ this idea of chronology between events. Cause and effect means that something has to happen, the cause has to happen before the effect. The cause cannot happen after the effect. This is the fundamental idea of grandeur causality as well, that if you are familiar with time series kind of frameworks, the existing idea of grandeur causality essentially says that whether some variable has a forecasting power of another variable or not. Effectively, you utilize the idea of chronology, saying that A happens and then B happens. If that keeps on happening systematically, then you suspect that possibly A has something to do with B, or at least A somehow causes B. But one of the biggest problems in economics is that, or most of the systems that we see around us outside the laboratory setup, is that not only the first idea does not hold, which is ceteris paribus, the other idea also does not hold, because expectation disrupts our usual idea about chronology. If I am expecting that I will be hit by a bad shock, so it can be like a fire in my house, for that I will purchase the insurance right now. So if I simply keep track of when someone is purchasing the insurance and then when something else happens, let's say a fire breaks, going by the idea of grandeur causality, I will say that the act of purchasing insurance causes the fire. But obviously that would not be correct, right? So therefore we cannot even employ these kind of ideas either. And this is actually one of the big problems in, especially for ideas like bank runs and so on, where so bank run is effectively something like a herding behavior, where a bunch of people suddenly go and try to take their money out of the bank just based on a rumor. I'll not get into the details of that. The point that I'm trying to give out here is simply that expectation changes our idea of when a cause happens and when an effect happens. And especially given an expectation about a certain effect, if you change your behavior right now, the usual idea about A succeeding B and therefore possibly B causing A, that idea does not work anymore. All right, so in that case, my hands are tied, because observational data will fall either in these two categories. And if I cannot do that, then in that case, what do I do? How can I make a causal inference about something affecting something else? So here are two kind of brainstorming ideas. If you are from economics, potentially you have already gone through all of these things, but if you are not, then maybe there can be something interesting here. So the first one is that imagine that you want to get into a program evaluation for school and college students, where you simply say that, look, this is voluntary. These are, let's say, standard 12 students who will go for board exams and then appear for something like, let's say, a joint entrance kind of exam, engineering, medical, whatever. And you go like after the usual school time ends, voluntarily. If the students come, there will be some additional classes that will be held for them, right? Maybe out of 100 students, 20 of them show up, they do very well in the joint entrance exam. Can I causally say, attribute that because of my program, they did well? The answer is no, because this is the problem of something called problem of counterfactuals. Counterfactual is something that has not happened but could have happened. If I did not float that program, maybe these students were the more excited ones, more energetic ones. Because I floated the program, they went for it. If I didn't, they will do something else and still crack the joint entrance exam. So then the problem is that I am not seeing the counterfactual. I am seeing only the so-called this, in this language of econometrics and statistics, this is called the treatment. As if I am assigning a certain type of treatment, which is the imparting the knowledge through the program and then seeing the outcome. And maybe that is not what is causing this effect, final effect. So there is a problem. The second one is that for macroeconomic context, yeah, please. I'm getting to that. So the second problem is that this has to do with, again, how policymakers change the perception about causality. That one of the standard kind of toolkits for central banks has been that if the economy is slowing down, they try to cut down on interest rate. Why and how, let's not get into that. Roughly speaking, the idea is that if interest rate goes down, loans become cheaper, hopefully people will take more loans and then maybe invest on that. Whether it works or not is a separate issue. Let's say that that is what they do. And that's actually globally acceptable policy lever, that in case the central bank thinks that there is an impending recession, they will start to talk about cutting down interest rates. In fact, this is what you would also see for the US Fed right now. They are having this discussion on whether to cut down on interest rates or not, which is what is also making the investors unnerved that are they expecting a recession to come up in the US. Anyway, now suppose you are an econometrician who simply keeps track of when the rate is being cut down and then when the recession is happening. Now let's say this policy works. Instead of the recession happening, let's say by -5%, it arrests it to -2%. So there is a net gain. By cutting down interest rate, it could have been -5, but because you cut down the interest rate, the fall is arrested at -2%, let's say. Now, if you simply keep track of the data, then you will see that every time the interest rate is cut down, then the GDP goes down by 2%. What is the problem? Again, I am not seeing the potential -5%. That is the counterfactual, right? This is one of the classic problems in economic setup, that for the same entity, I cannot see the effect of the treatment as well as not the treatment. For us, only one timeline exists. Whatever we have done, we have done. We do not see, if I did not do that, then what could have been the case? Then what do we do? So then one of the kind of standardized things, given that it's public health crowd, I guess this is the first thing that would come to someone's mind, that go for group differences. And this is where your point also shows up, that create a control group and see, but for medicine trials, one of the problems that was adopted in economics through cities and so on, but one of the biggest problem was that it's much easier to control for properties which are orthogonal to the treatment, because at the end of the day, that giving literal medicine can be orthogonal to your demographic background. For example, it's not related to religion, but a lot of economic treatments are not quite orthogonal to that. So this randomization suffers. Then the idea was that, well, so why don't we then do RCTs? One of the problems of RCTs, so RCT solves this randomization problem and then it develops the econometrics around that. The problem is you cannot do a countrywide RCT. So RCTs are typically very focused, very small group, and the results are not scalable. And because they are not scalable, they also suffer from out of sample, validation. So one of the major kind of improvements in the literature that has happened in economics over, let's say, around last 20 years is to think in terms of observational data, but then try to come up with some kind of natural experiment which has already happened. You did not design it. It has already happened, but cleverly find out some data where as if one treatment group has been created, one control group has been created, and then do some causal inference around them. So two basic problems, two basic confounders that can come up. The first one is that, for example, if I just went for collecting data on people's degree and their salaries, generally speaking, they are positively correlated. But can I say that degree causes high salary? So this is where a customary joke is that I say that degree causes high salary unless and until you do a PhD. So think about doing a PhD before you think that this correlation is positive. But the point is that it's quite possible that someone who has been going through this whole grinding for 15-20 years potentially has high persistence. Whatever he or she does will be doing at that level. So it's the innate ability which is causing both the degree and the high salary. It's a possibility. I'm not saying that is what it happens, but we have to control for them these underlying factors. And then the other thing is obviously that there is the problem of not random assignment, that if you calculate, let's say collect some data on income and heart diseases, somewhat counterintuitively in some samples, you actually may find that higher income is correlated with higher heart disease. And obviously the causation should not be that higher income causes heart disease, unless and until you believe that the income is so high that people go, oh, how am I given this offer and then has a heart attack? I mean, that's possible, but a more likely scenario is that in order to earn that, that kind of high salary, potentially in a growing economy, what happens is that people would then switch out from the more regular, healthier alternatives for lifestyle, etc., that eventually builds them and causes. So, for example, dependence on fast food is a very well-known feature for the Indian workforce. I'm not making a value judgment here. I'm just simply stating it as an observation. So, I mean, then we have to find out the path accordingly, right? So, what are the major methods that people sort of employ here in the present context? So, some of these things are usual RCTs, regressions with control variables, IVs, regression discontinuity, and so on. So, two of the ideas, difference in differences, and this has actually made big inroads in economics over last 10 to 15 years, and synthetic control. So I'll talk a little bit about synthetic control as well. Let me just build a little bit of idea about DID estimator for a while. I know that, I mean, it's very evident that some of you, I know you already know it, but given that not everyone can maybe on the same page, let me still go through it, at least on the basis of intuition. So the idea is as follows, that imagine that over time is unidirectional here, right? So it's literally, there is a past and then there is a present, there is a present and then there is a future. So suppose something happens. So I'm plotting time on the x-axis, something happens here. So this black vertical line, this represents something that we will describe as treatment time. So it can be, for example, getting enrolled in a program. It can be, getting some cash transfer unexpectedly, right? And so on. On the y-axis, we are plotting the outcome variable. Let's say for, getting this, treatment in terms of additional training, the outcome could be whether you get into a good program or not. I mean, in that case, it would be binary. The way I've drawn the curve is continuous, but imagine that there is a, binary jump here. Or it can be simple, something like, if I have received some amount of unexpectedly, some cash transfer, remember that this expectation messes up with causal effect. So we have to rule out that expectation. It has to be unexpected shock. Unexpectedly you get something. On the y-axis we can see how do you behave in terms of consumption and borrowing, let's say, which is more like a continuous variation. Now imagine that here you see that something happens, some values are there for your consumption, let's say. After you have been given the money, consumption goes up. Can I say that the difference between the average of pre-treatment and post-treatment is the causal effect? The answer is not quite, because I do not know whether something related to the treatment happened at the same time or not. Right? So in order to do that, what people try to come up with, and this is something that is kind of known in the literature, that you create a control group where the idea is that the treatment group and the control group differs only in terms of the treatment that you are interested in. The control group is not receiving the specific treatment that we want to study, but they undergo all other shocks that the treatment group does. In that case, what I can see is that there can be a pre-treatment difference, and this actually has been one of the biggest reasons as to why DID methodology kind of swept through, is that it does not need to be identical. The treatment group and the control group do not need to be identical. They just need to be statistically similar, following similar trends. So this green line does not need to coincide with the red line, even in the pre-treatment period. It can be anywhere, doesn't matter. I can keep track of the group after the treatment has happened and see what happened to the treatment group. Now here, the way the graph is drawn is that you can clearly see that the difference kind of increases, right? Now, which difference I will say that this is the true treatment effect? Is it that difference? Is it a difference from this one? This is what the name comes from, difference in differences, which is that it should be this difference minus this difference. So the way to do it is that you create, kind of extend this line, which is the red dotted line, and find out what is the difference here. What is the, why is this red dotted line so sacrosanct in this? Because this gives us the as if scenario. This is the counterfactual. This has not happened in reality. Here we are sort of attributing what would have happened to the treatment group had it been not assigned the treatment group based on the property of the control group. And we are kind of projecting it there. Now, how do we capture this thing sort of econometrically? Do not worry about the slide numbers. These are just the first set of slides. Then I will go to next set of slides. I'm not ending right now. You will be tortured for a much longer time. All right. So what is the basic econometric setup? What do we do here? The idea is that you can keep track of any variable. So the first entry point is that imagine that you are keeping track of a bunch of households. Each of them you identify by a household identifier, call it I, at any given time point t. Then the idea is that you create a time dummy. You can call it a treatment dummy as well, that before the treatment occurs in time, you call it 0. You assign a 0 value to it. After the treatment occurs, you assign 1. Right? But remember that I want to find out this difference. Right? So I have to look at the treatment group post the treatment in comparison to this red line. Right? So you create another dummy, which is treatment, the group that is being treated, and the coefficient of interest would be this beta 3, which is the interaction of these two. The interaction being for the treated group after the treatment has been assigned in comparison to that counterfactual. And if you have more dimensions, more, let's say, demographic dimensions, you can plug them in for some j dimensions. There can be, j can be 1, 2, 3, 4 till j. So it can be something like, let's say, consumption of the ith household at tth time point, or it can be something like, let's say, propensity to recover from a disease for the ith household at a tth time point. You have all of these things, and then you can plug in a bunch of these j dimensions. So there you can plug in a whole host of things, which can be whether there is a difference in terms of religions or not, whether there is a locational difference or not, how close they are to, let's say, a polluting a water body or not, etc. All of these things can be accounted for. More importantly, even if you are not observing certain things, but you believe that that stays the same over time, you can still plug in some fixed effects in order to absorb those unobserved heterogeneity, even if you are not observing them. As long as they remain the same at the group level, you can absorb them in these effects. At the end of the day, what do you worry about? It's this beta 3 coefficient, right? Now, with respect to this, what do we have? Roughly speaking, the takeaway is that given the heterogeneity across firms and households, I'm talking of primarily from economics perspective, but it can be, this DID method is applied now much beyond economics. It's now very common in epidemiology and so on. But it's very useful to capture heterogeneous responses, and more importantly, rather than correlations, you should go for conditional sort of correlations at the end of the day in order to pin down these effects. So now in the residual 35 minutes, I suppose, let me spend some time on two different projects, and I would like to spend some time on the data construction and how we constructed the sort of treatment and control to see how one can evaluate some of these external sort of shocks. If you are interested in the sort of technical background of it, there is a fantastic book by Invens and Rubin. It's called Causal Inference in Statistics, Social and Biomedical Sciences. It has now become pretty phenomenal material for this thing. Or if you are interested more in the economics perspective, look at Cunningham's book on causal inference, the mixtape. And Angris Pishke become, so they finally gave the name mostly harmless econometrics. And people started to utilize this book so much that people started calling mostly harmful econometrics. Without knowing, people just run a DID and then show some results or some causal inference. All right. So this is something, both of these projects are with my long-time collaborator, Chirantan. Sawan was my PhD student here at IIM. He's joining IIT Bombay in, I think, in a month's time. Aparna she was a physician, a very accomplished one, and she runs this NGO. And after we started to talk to her, we got to, we thought that we got a very interesting idea, and I'll, describe what it is. Let me first tell you what she does. So, they started this program called Arman. Sorry, the program is called M-Mitra, which is Mobile Phone Mitra. And the NGO is called Arman. So what they do is as follows, that they work around Mumbai. They will give, so essentially what they do is that they identify very poor women in the neighborhood, those who cannot directly go to doctors and consult them. And she's a gynecologist. So this whole Arman project focuses on the gynecological problems of women. So whenever someone gets pregnant, right, there is a cycle of 9 months where the medicine requirement and the food requirement changes. Do not ask me how it changes. They have a kind of standardized template for that. What they do is that if one has registered for it, they will give phone calls free of cost and remind her, that woman, that this is your nth week, nth month, have XYZ medicine and have ABC food, right? So this is like an informational phone call. And then so they recruit them in two different ways. Let me actually show you the. So they have a form which looks like this. So along with the names and so on, they will take the, I don't know if you can read it, the pregnancy history and some data around that. And for us, the more important thing is that they will collect some information on which category of income does the women belong to, whether the phone is owned by the household or by the women specifically, and so on. Now I will get to the, so this is the background, right? And they keep track of this through call center for, for a few years now. So the reason I got interested in this, and then I will show you some literature around this problem. So the idea is as follows: that during COVID time, if you remember, there used to be this recorded message that used to be played on the phone. That if you're calling someone, initially there will be almost like a 1 minute long, I don't know, like 30 seconds long message, and which will say that you do X, Y, Z, wash your hand, blah blah blah. If something happens, then do this. So for a very long time, I used to wonder that. I mean, initially I used to get annoyed, and then I used to like, are people even listening to it? Do they remember? Even if you provide them information, do they remember what was the content of the information? Because a lot of the times you keep on getting these phones, maybe these are informational, maybe not. You simply disconnect it, right? So it's not an economic choice. It's a question of having finite time, and you do not want to listen to this kind of things. And most of the time, people justify by saying that when something happens, then I will get to know about it. Right? Applied, right? We are not very fond of collecting information and then storing them and then suddenly going out and acting on it. So the question was that if we believe that spending this much time for 140 crore population is potentially a welfare loss, let's say, what is the gain out of it? Are people really becoming more and more serious about it? Or they simply disconnect it and then call once more, because the design was that if you disconnect and then call, then it would not play. So we got very interested in this, and at that time, at that time, someone was working with me, and Chirantan was also here at IIM. So we got in touch with Aparna. It turned out that they were making these phone calls via this agency, who were keeping track of when the phone starts to, when the woman picks up the phone, to a fraction of seconds to when she disconnects. So you can actually see. So the idea is as follows: you know the record length of the message. So it could be something like, let's say, 53 seconds. And you know when one woman cuts it at 9 seconds, when someone disconnects it at 31 seconds, and someone who listens to the whole thing and then disconnects, right? And this is something that you can do over the few years for which they had data. So then the whole idea was that when COVID happens, then suddenly everyone is back home. I'm talking about the lockdown period. And also, COVID is a medical emergency, clearly. Do people start to listen more to this message, which is unrelated to COVID? Right? Now, in that case, the point is that you have to then construct a control group. So I cannot observe only the women, how they are behaving pre and post COVID. I have to have a control group as well. So here, the way we created the control group was, where is the design though? Before or after? So here is roughly the study design, that from January 2020 to April 2020, and then it goes to July. So 4 months, and then 4 months pre, let's say around 3 months pre, 3 months post. We took exactly 1 year before. So whatever would be the monthly. So for example, you can say that, look, in January, maybe somehow they have some more money and so on because of the year end. Maybe that leads to a change in the behavior. So I have to have an appropriate control group. So the way we did it is that we went back exactly 1 year back in time and dug up all the women who were registered in the exactly 1 year prior and how they behaved 1 year back. So this became our control group. So the idea was that if there is any seasonality or any fluctuation whatsoever that we even cannot observe or we cannot theorize about, that will be captured by the control group. Pre-April, so till March, January, February, March would be sort of identical for both of these groups. Identical as in similar trend. It does not need to be again coinciding. It can be a similar trend. Whatever is the difference appears, that would be treatment group cross COVID dummy. Lockdown happened in March end. So then we went for a whole bunch of things. Now let me just show you some of the average statistics. So we had call duration, and another very interesting thing is that with the call duration, they themselves, without kind of putting it to use, they themselves color coded it. So it's like green, amber, and red. So red is someone who picks up the phone and disconnects it. Amber is somewhat in between. Green is someone who has listened to it for more than I don't quite recall the exact cutoff. So something like 3/4 or more, right? Then what we have is husband phone owner. Actually, this is not an appropriate term. It's more like the family owning the phone. But we assume that, well, who else will own the phone? It has to be kind of the husband. Or it can be something like mother-in-law or whatever. In general, we are proxying it by calling it husband being the phone owner. Whether someone is being enrolled via community, or so the way these women can come to the hospitals is that, this NGO is that they can either sometimes the NGO reaches out to them. So it's almost like if some woman is already an audience to this NGO, often they say that why don't you go back and ask your friends also to come to the same NGO. In order, there is no monetary payment. It's just all non-monetary, non-pecuniary kind of setup. And the other, so this is called community recruitment for them, or they themselves can directly come over to seek information. And finally, whether they're low income or high income. So low income, high income is just whatever the income distribution is. We take the less than, below median, more than median, and so on. So what we see, and here is kind of the TID setup that we have. We are keeping track of the call duration percentage and call duration range in two different estimates at the woman time level. So the observation is the ith woman at tth time point. Treated group is the 2020 cohort, because they are the ones who went through COVID. The control group is the 2019, and the COVID dummy is the time difference, pre-lockdown and post-lockdown. And then we plug in a bunch of fixed effects to observe the unobserved heterogeneity and so on, right? So some of the things that we see is that it's really the case that after COVID, after the lockdown, they started to listen more to these phone calls. Because you can see that there is a spike in terms of, listen as in at least we can keep track of how long did they take to disconnect the phone. Now one can still play devil's advocate and say that, no, they just held on to the phone. What is the guarantee that they actually absorb that information? We do not see any welfare effect. So the reason is that currently the science, the medical science has progressed so much that you do not see a lot of difference between having a negative effect for pregnancy. At this margin, it does not, the outcome does not vary between not a pregnancy to a pregnancy. This is not like, we have crossed that stage long time back. So we do not quite see a welfare effect coming out of this. But at least we can, that's why we pieced this idea as technology engagement. We do not know what happened after engaging with that technology, but we know that at least the engagement increased. So what we can see is that in 3 different specifications, so these are just different fixed effects that are being absorbed. So you should look at the top column, and here it shows that the average engagement really goes up for these women, and around 3% increase over a mean call duration percentage of 45%. I'll skip this because that would not be very important. So here are some mechanisms, very interesting mechanisms. So when we saw that if the husband is phone owner, so then once we identified that they are engaging more with phone calls, the question is why? So one of the things that we saw is that if you interacted with the dummy of whether the husband is an owner or not, that is significant and positive. So we thought that it's a kind of useful mechanism, because during the lockdown period, everyone is home. People cannot go out. So if the husband was the phone owner, and if he was working outside, he would take also the phone outside. So if in between a phone call comes, he cannot come back like 10 kilometers and give the phone back. That is simply not feasible. But if the husband is already in the home, the phone is also in the home. So therefore, it's a question of accessibility. So which we think is very consistent, that if you interacted with the husband being the phone owner, that effect is even larger. that they are the ones who are listening to it even more. The second one being enrollment channel, those who enrolled via community. Community being, I think this is something that I was been talking with Aruna about, that if there is a peer effect, that somehow, so here we don't have a good strong hypothesis as to why that happens, but seemingly peer effect matters here. That during COVID time, maybe they were just, these women were talking to each other more, and then, but in all honesty, we could not probe further into it, that why a community channel is working here. The third one we have a good hypothesis about. So what we see is that low income women within that group, who is already low income, so it's like low of the low income, they tend to again react more. And we think the reason is that they have even lesser amount of resources to go out and seek sort of medical information during that time. They're relatively, literally the poorest ones. And this is something that we kind of hypothesize a lot in economics, that marginal value addition sort of goes down the more you accumulate something. So for the poorest ones, the marginal utility or marginal value addition for practically anything and everything is very high. If you give them something, they'll immediately consume it. So that way it's kind of very consistent with that behavior. So again, these are pre-trained plots. I will skip them. Yeah.
In the summary statistics table, for the green,
Yeah.
for green, the mean time is actually declined. Oh no, I'm sorry. The above the top row is
No, so actually this would not be the best way to see the summary stat. This is within the same year. One has to compare it with the next year. So it's a difference in differences. So I mean, this is just one difference. But now let me actually get into that in terms of what happened really with this, green, amber, and red. So I'll not get into the fine. Yeah. Yeah. No, it's actually not the same group. It's the earlier group. So it's a cohort DID rather than a panel DID. Yeah. Yeah.
maybe that will answer my question.
Mm.
Who are using this over time, you would expect that towards over time there will be a learning, right?
That will get cancelled out because of the control group. So unless you suspect that learning is happening differently across time, that will be absorbed by the control group. No, this is like, I have now forgotten the localities, but this is far spread over the around Mumbai. So these are some Mumbai slums. But along with that, so this is like you go to, I'm very bad with names. So it's like not literally like a small community that's the same set of women are doing. Yeah, no, it is very minimal. That is something that we were actually a bit worried about, that what if there is cumulatively a community knowledge that is building up? That is not the case here. No, fair enough. But in this case, it's simply not. So it's like literally, I mean, when I say Mumbai, it's suburbs of Mumbai included, and it's many different places. And the geographic spread was not particularly concentrated in any region. That is something that we could not control for. Fair enough. But if they come back again, they will be assigned a different number. So if they, but what would be the chance that someone gets pregnant in 2019 by July, and then by December January 2020 again comes back for another pregnancy? Unlikely. There will be at least one. I mean, I don't know what would be a decent case. No, that's possible, but there has to be a physical difference, right? So it cannot be literally 2 months. Often they disconnect. So basically, it's like if you're working as a mason somewhere, you are not allowed to pick up the phone. You'll just disconnect. Like, no, you might, but generally speaking, they Yeah, they will be counted in our red group. Yes. So actually, this slide is about how they switched across different engagement levels. So what we see is that much of the gain happened in the green group. Amber and red lost its mass. So what it means is that the relative fraction of phone owners who were in the red group, that is decreasing. So earlier people, a significant some number of people were disconnecting the phones. Now that fraction is reducing a little bit. Amber has lost the most, which is that it's the middle group who were engaging it to a moderate extent. That number is also shrinking. What is going up is the green group. So what it means is that the number of people who were listening, or fraction of people who were listening to the reasonable extent of the phone call, that fraction is increasing. Right? So the shift is from red and amber to green. Now with this, in the and then we did some cuts here and there, but let's not get into that. So here, where do we sort of control? Possible. So one of the ideas could be that that is something that we wanted to check out, is that what are the outcome variables. So this has been one of the things that actually, it's a nice question that brings me up to the question by Abhijit Banerjee's famous paper on RCT, where basically what they tried to tell people that he recorded himself. At that time, he won Nobel Prize and said that, like, we are reasonably famous, let's say, public speaker, public face. So if he gives out some information on COVID-related things vis-a-vis some other informational videos, they had a very carefully designed RCT done in West Bengal to see whether that has an impact or not. Right? Turns out that people actually give more attention, but the impact is not there. So they had some measurable outcome variables as well, that how long do they spend in terms of washing their hands? Do they go back and tell their children as to whether they should wash their hands or do some sanitary checks and so on? That does not change very drastically. So this problem, so what? This question is there, that, and this is actually the first question that I began with, that then why provide information to begin with? Right? Because you're wasting then everyone's time. We do not know whether people are actually implementing that or not. So we regress when we checked whether this leads to better maternity outcome or not. That outcome is, in all honesty, it's so coarse grained that this one will not change. It's like having a little bit of medicine will not change the final outcome. If someone can keep track of, let's say, some more fine-tuned biological markers, maybe that will show a change. But behavioral change has known to be very sticky even in the RCT literature. And here I suspect that something very similar would happen. That what is the behavioral spillover in terms of the actual welfare outcome, that I don't think will shift a lot. But what we can see is that technology engagement changes. And with what we could pin down on is that primarily it happens to accessibility, potentially not being able to do practically anything during that time, and during lockdown time, possibly they were looking for any sort of entertainment. So if a phone call comes, for all we know, that could be an entertainment rather than information. So we do not know exactly why or what did it lead to, but we can see that it led to changes. And the NGO was very happy because they knew that at least people are listening. So a lot of these companies are very worried that they do a lot of things, no one engages with them. So this one was at least in some ways useful to know that, oh, okay, during these times people at least engage more. That is something that would be actually quite useful. What is the long-term effect? You see, at the end of the day, there is a general equilibrium effect as well, that as long as these things are novel, people tend to react in a certain way. The moment you make it a more standardized, like everyone starts pushing in information, generally people become immune to everything rather than just one or two things. So there is a very high likelihood of that also happening. So the framework that we thought about, and this is something I did not show here because that's almost entirely just undergraduate economics. think of a labor leisure choice. So there is a cost of engagement because you are losing out on your daily salary, or you are getting scolded by the supervisor that you're not supposed to pick up the phone and so on. Because the NGO, whichever call agency that they have, the phone, a telephone agency, they are not going to call in a certain time. They will call up whenever they can. So if it is 12:30, they will call right then and there. But that can be disrupting the work. And that's why maybe those women were not listening to it earlier. So we do not know because we do not see them in their workplace. No, we see only this form that is collected by this NGO where they say that they work and some coarse grained amount of salary. This is the unfortunate part where we do not entirely see what they are doing outside that NGO. So I have 10 more minutes. Let me just quickly show you one more study where we kind of utilize something very similar. This project is still going on. I should have updated this time. I mean, this has been going on for 4 or 5 years now. This is with LV Prasad Eye Hospital. This is one of the largest eye care chains in India, along with Shankar Nethralaya and Arvind Eye Care. So Dr. Anthony Vipin Das and Raja Narayanan, they are, the way I put it is that, I hope you won't be offended, they are not the fake doctors like economists. They are actual doctors. Those who can actually do something useful. And again, this was with Sawan and Chirantan. So here, what we did is, I will just give you the story in short time, and I will not get into a lot of details. There has been a debate in science about how science progresses for a very, very long time. That's about the philosophy of science. So one view is that science is kind of progresses by small steps, right? So innovation A happens, people adopt it, then innovation B happens, and so on. There is a countervailing theory around it, which is that science progresses by a death at a time. What does that mean? People hold on to certain thoughts which do not die till the time they die. In other words, it's typically a cohort-based idea, that one cohort comes with a set of ideas. They will cling on to it till the time they sort of find solace in that. And then when they retire, this is where it gets, kind of a bit problematic. But when they retire, then the newer cohort sort of comes up with a new set of, ideas and so on, and that's how it progresses. So this is the, Kuhn versus Popper kind of, philosophical ideas about how science progresses and so on. Now, why do I talk about this? We started this project with LV Prasad Eye Hospital with we have been in discussion with them, and they actually, in this case, they came up with the problem. So the problem was as follows. It's an eye hospital which specializes in various types of eye surgery, cornea transplantation, and so on. I don't even know, like they do billions of things. But two of the things that they, one of the very standardized things that they do is that in case someone has a problem, especially around glaucoma and so on, they do first do a scan of the eye. And for that, they have a very standardized machine called OCT, optimal coherence tomography. Honestly, I don't know what it means, right? It's some kind of a scan that they are familiar with, that they do. This is something of, let's say, 15 years old technology, or maybe 20 years old technology that has stabilized and that they keep on using. A new form of technology that has come up, a scanning machine. It's produced potentially by Zeiss. I'm forgetting the name of the company, who created an angiography add-on to that. So the whole thing became OCTA, optimal coherence tomography angiography. And it turns out that apart from changing the name, it gives you a lot more information, right, around the eye. And it gives some parameters, some ideas about the disease, which is a superset of the information of what you get via OCT. So the other way to think about it, if you get confused about the name, the longer name OCTA is also the superset of information of OCT. You get the usual OCT information, along with that you get an angiography. The problem is, one has to spend considerable amount of time trying to understand how to read the OCTA scan. So they got all of these machines, and these are extremely costly machines. So each of these machines can be 5 crores to 8 crores and so on. And then no one was using it, or very few people. So the hospital keeps track of how many times. So they have a very good EMR system where they can keep track of the footfall, and they can see how many times OCTA is being utilized and how many times OCT is being utilized. But they saw that somehow it's supposed to be the case that everyone is supposed to switch to OCTA. It's a newer technology, better technology, cleaner, gives more information, but people are not switching. And here you cannot say that people are not educated enough to understand, because they are some of the best eye physicians in the whole country, maybe in the whole Asia Pacific region as well. So these are a very selected group of people who are extremely highly trained. Somehow they cling on to one technology. The question is why? So when we started to look into that, and that's where we found, that's where we again thought of utilizing the COVID shock for a very specific reason. And I will tell you what was the reason, to see how people reacted during that point of time. So let me just quickly show you one picture. Do not ask me what it means. This is obtained from them. This is the Zeiss OCT. Sorry, the new one is the TopCon. It comes up apparently with a bunch of additional parameters and so on. The only takeaway for us, at least for me as an economist, is that the right one requires a different sort of training, which people did not always have. It's the left one, which is the more usual standardized kind of technique. All right. So what we thought is that we cannot exploit anything which is related to this technology to see how the technology shifts, because you remember how the treatment has to be orthogonal to the treatment group. So for example, one cannot introduce a certain type of, let's say, training sessions, which is why I gave that example, and say that, look, now OCTA increases, because what if people who were interested in that training to begin with, they showed up, right? So there are these kind of problems, so which we have to avoid. COVID is, economists were very happy with COVID because it's completely unconnected to economics, and that's why one could have a lot of exogenous variations everywhere, right? So what we thought is that, look, it changes the situation in two different ways. And also, just to clarify why I chose this also to talk about here, is that this is again non-pecuniary. The machines had already been, they are already there in the system. No one is paying any additional money for that, right? So the choice is not driven by monetary units. The choice has to be driven by something else. So here was our study design, and here is the basic idea for that. During COVID time, people were more worried about their lives than their eyesight. That is something that potentially we would all agree on. So what these guys do is that they have this very interesting CSR setup, and the doctor who created this whole chain of hospitals also believed in a certain type of philosophy. So what they do is that I myself actually got enrolled to see their system. So if you enroll, they will ask you which category where you want to enroll. So there is one site saver category. So typically you and me will be enrolled in the site saver, which means that you will pay for your own care. Along with that, you will pay a premium explicitly, which will cross-subsidize poor people's treatment, those who cannot pay. And this is very upfront. There is nothing hidden in it. They will say that if you want to belong to the site saver category, or there is one category where you just pay for your own treatment. The third group is where they will send around buses to nearby villages and so on to get people who cannot get treated, and then will treat them absolutely for free. And this is something that we have talked with them multiple times, that if the physician knows whether someone is in category A or B or C, whether that changes their treatment regime or not. They categorically said multiple times that no. They can see the information, so that's a confounder in our design, if you want to be devil's advocate, but everyone said that no, we do not assign treatment based on which category you belong to. So let's imagine that what they are saying is true. And let's assume that there is no unseen bias here. So here our idea was that during when COVID time, COVID starts to happen, two changes happen. One is that on the demand side, people with those who have lost their eyesight by the largest magnitude, only they will show up. The ones who are on the sort of on the margin, that if you think that, yeah, I would like to go to the hospital and get my eye checked just as a regular checkup, you would not do it immediately at that time. So the demand side will shrink, and the average eyesight will be lesser for the demand side than pre-COVID. So there will be a demand side shrinkage. On the supply side, COVID was also related to doctors' age, in the sense that the doctors had to go to the hospitals, but most of the time it was like if you are more than 50 and so on, people, there were government advisories saying that be careful about it, go less frequently and so on. So on the supply side also, you see a sudden shrinkage in terms of number of doctors, but the average age of the footfall of doctors, that goes down in the hospital. Now, this is something we can see explicitly from the EMR data, because we know who is coming in, conducting what kind of surgery or prescribing what kind of medicines on the patient, where you can keep track of what was the entry level eyesight and what is the exit level eyesight. So you can actually measure the welfare gain, which we could not do in the earlier case. I can actually see what is the welfare gain that you came with. So they have these logmar scales. I don't know what it means. So they have some kind of scale like going from minus 3.5 to plus 2.5 or whatever. So there is something. So you know that someone came with minus 3.25 and it went to minus 1.75. Entry to exit, and for every visit they record it. Yeah. Yeah. So when we started to do that, then we did. And there are some very interesting anecdotes for that. I'll get to that in a second. Whether it's good or not is something we can debate out, but I'll actually give you one or two reasons very shortly. So, all right, so I guess I'm running out of time. So here, this was our idea that there would be this shock now in this market will create a disruption in the demand side as well as on the supply side. So what we did is to set up, I'll skip the theory and so on. I'll just directly get into the sort of DID setup. So again, what we did is to, at the patient time level, we can see the visual impairment, whether they are non-paying or not, taking the paying group as the control group, and then whether they interact more or less with the COVID or not. The non-paying group, remember, they have to traverse a long distance from the villages to show up to the hospital. So the opportunity cost for them is extremely high. That's why we took them to be the treated group. So this was our first estimation. The second one was whether OCTA usage went up or not. The third estimation was what is the welfare gain, change in visual impairment when they are entering the system and when they are exiting the system. When a certain treatment regime is finished, then what is the gain in eyesight in real numbers, right? So, and here we basically what we see is that visual impairment during the first visit really went up. So our first hypothesis is true. People with, so this one is impairment, so higher number is more impaired, right, or less eyesight. That clearly goes up. Then the second was that if you take the non-paying cross COVID, so here we took, if you look at 4, 5, and 6, these are OCTA versus OCT. Clearly the switch happened. Number of OCTA treatments went in fraction more than OCT. So somehow people were switching. Why is a different question, but they were switching. And once we do it for OCT and all other scans, so we asked the doctors that apart from OCT, what could be other equivalent scans? Whatever they said, we took them up and clubbed them under all other technology. Everywhere, OCTA increases. Then I'll skip these things. Then what we tried to see is that can you distinguish between the demand side and the supply side? So for the demand side, what we did is that we knew how long, how many visits they had, how much time they were spending in the hospitals again, because of the EMR data, when they're exiting the hospital and they're coming out of the hospital, that can be captured. More importantly, we could control for visual impairment in the first visit. This is very important because it's possible that if you have, let's say, -3, which is the lowest impairment, from there the gain can be much easier in the beginning. But the further you go up in eyesight, then the corresponding gains can be more and more sticky, right? So we controlled for that, and even then we saw that OCTI increases. So it's not entirely driven by demand side. Then we looked into what happens in the supply side. So what we did is that we split the doctors pool. This is a bit shaky because the number of doctors, given that it's one hospital, it's a little small sample. So around 60, 70 doctors. So given the guideline, we split them into less than 50 and more than 50. And turns out that the increase appears almost entirely from the younger doctors. So we thought that then it kind of says that from the demand side, the moment there is a shrinkage and fall in eyesight, it requires more sort of advanced treatment and more immediate treatment, more information at one go. That pushes OCTI usage. And on the supply side, given that fewer older doctors were there and they were not using it, almost entirely it came from younger doctors. This is where we went back to the doctors and we said that, look, there is something interesting that is happening here. Can you tell us why? So some of the things that they said is that, one, the younger doctors who came out during the previous, let's say, 10 to 15 years, they were trained to OCTA to begin with. For the earlier generation, they had to learn this new technology, OCT. So the younger doctors did not learn the OCT per se, they learned the OCTA to begin with. So that was the only thing that they do. And the other thing was that for this cohort, often they were also in the administration. So they could not spend enough time to sit in the courses, etc., in order to learn a new technology. And they kind of had like, I have spent 30 years here. I have, fixed so many problems. Why would I need to, do these stupid things? These are for, younger kids. Let them do it, right? I'm making it a joke, but at some level they had this idea kind of almost coming out like that I do not need it. I know how to treat it, and people have become significantly better over course. So therefore, again, that's where I'm saying that whether it is a good argument or bad argument remains to be settled. But this is something that at least the hospital did not know. So then we went after the visual impairment gain, and there again we saw that, yeah. They did not. They are much more interested in the actual medicine side than the management side. So they are much more interested spending money to understand how this works and so on, rather than exactly why it worked. It's only after we created this research agenda and so on, then it did not even occur to them very seriously that this is even possible. So after we presented it to them, then they said that, so it sounds feasible. But before that, they were looking at medical solutions, that what would be the way to change it and so on. Like, should we get yet another newer variant of that and so on. They were not looking at it from an economics or management point of view, let's say. Anyway, so what we also then see is that the visual impairment also decreases by a large amount with respect to this. This led to a bit of a conflict in terms of our understanding that at the end of the day, this is a scan. Why would this lead to gain in visual eyesight? Or so then the doctor said that often they change their prescriptions based on scans themselves. So there is a causal pathway there, that the doctors also said that it kind of makes sense, that why the visual impairment will fall by a larger amount with OCTA than OCT. Anyway, so let me now sort of kind of finish it here just by summarizing this. One of the ways now I want to explore further into this is that at the end of the day, this is within one organization, intra. But how inter-organization knowledge spillover happens can be a very different mechanism to begin with. So that is one thing that I would like to spend more time on. The other thing is that after COVID went up, I went back, and then we kind of did some summary stat. The utilization of OCT again went down. So a lot of times these changes are very temporary in nature. So creating persistent change is very, very difficult. That is sort of my learning out of these two projects. Anyway, so I would like to end it here. I hope you had some of these ideas about the methodology and the contexts where these things can be very useful from an economics point of view. If you're interested, I'll be more than happy to talk. I stay literally 15 minutes from here. So it has been a pleasure to come back here and to talk to all of you. Thanks for listening to me.